This is so weird to do it out earphones. Good morning, everyone.
Good morning.
Always good to hear a voice.
So today we're going to kick off, try to continue to stay on time. You'll notice that I'm masked up, but it's because I'm here live with Dr. Parker.
Hello, everybody.
So, yeah, I guess we're going to continue our conversation about alcohols today, but we just want to start the class off again, making sure that if we touch base and see if anyone has any questions about the material, about class in general. Just while we're both kind of present in the room, if anyone has any questions, now's a great time to ask them.
I was wondering, I think it was this class, did you say you were going to be making a study guide for us for next week's exam?
Yes, I will be. So I'll be putting that study guide together, probably releasing it around Friday, just because we'll have gone through a majority of the material then. And hopefully that gives you plenty of time to kind of actually apply and use that study guide.
Thank you.
Yeah, of course. Are there any other questions or concerns at this time?
Will this study guide kind of highlight the depth we're supposed to go into? Because I think sometimes I get a little bit confused with the slides, just how far I'm like supposed to dig down for information in the exam, especially like the metabolism and pathway things.
Yeah, so I'll definitely, I think, point out things that you need to spend a little bit more time on, things that you can kind of discard in terms of depth. And then I guess if you have any questions about that like individually, I'd be happy to answer those. Again, this isn't necessarily a biochemistry course, it's a pharmacology course. So I think at least when I'm writing the exam, that's going to be the stance that I take when I'm writing questions. I want them to be far more pharmacology focused. But let's say you're talking about the metabolism and the pathways. If those pathways or those enzymes are sites of pharmacological action, then it's still kind of like open, open for interpretation. And like today we'll talk about some pathways. We'll look at some pathways. You obviously don't need to memorize the entire pathway, but there are going to be some key enzymes that you're going to need to know, let's say for the metabolism of ethanol, but it's not going to be every single enzyme that's on that slide. So hopefully that, again, gives you a little bit more peace of mind in terms of not having to memorize an entire pathway.
Yeah, that makes sense. Thank you. Like, I know it's all important. I was just like sort of trying to get in an order of what to really go into first, but that helps.
Any other questions? Are you good? Okay. Dr. Parker's gonna go get his flu shot. We're gonna have lecture. Have a great day, Keith.
Thanks. Good day to everybody. See you at 1 o'clock. On Zoom.
On Zoom. See you at 1 o'clock on Zoom. Okay, sorry, just gonna take a second here. I can usually hear everyone better, and I think you might be able to hear me better if I go to my earphones. I guess as usual, if you have any questions, feel free to pop up any of your questions in the chat. It's a nice way to just, again, kind of ask your question, and I don't want to say a non-invasive way, but just kind of a nice way to ask a question kind of through the continuity of the lecture. And today we have our double header. We'll be discussing alcohols. I'm not quite sure if we'll get all the way through the remainder of this, but then we also have, our period at 1 o'clock. We'll finish up alcohols, and then we'll start talking about general anesthesia. Okay, so the roadmap, just where we've been, where we're going specifically with alcohols. We've talked about things like history, the use, to the next step in the process here, we'll be talking about things like enzymes that are important for the metabolism of alcohol. We'll talk about methanol and kind of the relationship that methanol and ethanol have to one another. And then ultimately kind of wrap up talking about some of the effects on CNS, the sites of action, We'll talk about both acute and chronic alcohol exposure, essentially, and then wrap up talking about the effects of the endocrine system, as well as some pharmacological interventions that can be used for the chronic use of alcohol. I am going to try to, again, keep it slower today, pause when I can, and if at any point in time you're just like, I need you to slow down, literally just private message me in the chat. I'm keeping that up on my screen, and it's just a nice reminder for me to slow down. Okay, so where we left off yesterday, we again went over history and use, and left off on this particular slide going over metabolism of alcohol and liver metabolism. So we went over some of the major enzymes that are important for breaking down ethanol, things like ADH, or alcohol dehydrogenase, ALDH, aldehyde dehydrogenase, catalase, and CYP2E1. ADH and ALDH are going to be kind of the primary pathways in which alcohol is processed. You can also see that some of these enzymes overlap with the processing of methanol. And so that's going to be very important when we talk about things like methanol poisoning and how it's treated, because these enzymes are actually going to be targets for some of those interventions. So here again, you can see ethanol, how it's processed via alcohol dehydrogenase to aldehyde. Someone had the question yesterday, is this kind of, are there any other downstream, I guess, output pathways for aldehyde? I did kind of a quick search this morning and I really didn't find anything. Almost everything that I found essentially came up with this, this pathway for the metabolism of alcohol, and literally just showing kind of this bottleneck to alcohol dehydrogenase. The other things I think important to point out while we're looking at this particular figure and we're following kind of this main pathway here, maybe I'll annotate this, is that you also have these cofactors that are important for these enzymatic activities. So the alcohol dehydrogenase is going to require NAD plus and is going to yield NADH plus H. And so this is going to ultimately also be a result of, there's also going to be a cofactor or an output that's important in this metabolic process. So once alcohol dehydrogenase is processed, ethanol, it yields aldehyde. Again, aldehyde is processed via aldehyde dehydrogenase, and that's going to yield acetic acid. And then from acetic acid, thiokinase is going to alter this to acetyl-CoA. And so this pathway, as we're looking at it now, is important. I'm not going to ask you kind of every intermediate here, but the sites of action of where we see drug interventions, things like alcohol dehydrogenase and aldehyde dehydrogenase, those will be two enzymes I think that are important to know for this process, because we're going to be talking about them not just in their enzymatic function, but also as they are targets for different drugs. So you can see here, obviously, if you are ingesting a large amount of ethanol, you're going to have large amounts of acetyl-CoA buildup and then production of fatty acids. And we'll talk about that here in the next few slides. Other enzymes that are important for processing of ethanol, the CYP2E1 and catalase are also going to be important. And just a note here that I've made on the slide is that each step requires 1 NAD plus. So 1 mole of ETOH requires 3 moles of NAD plus. And so slowly but surely, as you ingest more and more ethanol, you're going to be overwhelming the system. And so this is going to exceed the 1 NAD plus in the liver and limits your ethanol metabolism to essentially 8 grams per hour. So at a certain point, your liver is no longer able to break down that ethanol at the rate of possible consumption, depending on, again, your rate of consumption. Yes, so the red X's on this slide are going to mean that these drugs, which we'll talk about at the end of today's lecture, are inhibiting those enzymes. And so you can kind of predict what the effect of that is going to be if you're inhibiting those enzymes, kind of what the side effects of these drugs might be and the effect on the end user. So these particular drugs are going to be inhibitors for these enzymes. And like I said, we'll talk more specifically about these drugs a little later down on the road, but they're and kind of how they are administered, as well as kind of what some of the side effects of them are. Okay, so the effects of the NAD plus, it's going to limit the rate of ethanol metabolism, kind of like I said at the bottom of the previous slide. The function of the NAD plus enzymes are impaired, so alcohol dehydrogenase and aldehyde dehydrogenase. So you're going to essentially get this accumulation of lactic acid, reduced activity of the TCA cycle, and accumulation of acetyl-CoA. So for those of you who've taken biochemistry and maybe don't have the best memories of biochemistry, I am just throwing up that image here of the TCA cycle. Here you can see, again, how if you have that large amount of acetyl-CoA and you have a lack of NADH, you're not able to go through this process. So you kind of have a bottleneck here and kind of a buildup of that acetyl-CoA because you can't continue through the rest of that metabolic process because you don't have enough NADH because it's being consumed by these earlier enzymes in this metabolic process. Okay, so going to pause for a second. Are there any questions about ethanol metabolism, about these slides, about what you'll need to know for the exam? Just want to make sure if anyone has any questions. Again, feel free to ask verbally or pop it up in the chat. Okay, so again, kind of an extension of the effects of the backup in these metabolic processes. You're going to have that increased amounts of NADH, elevated acetyl-CoA, as we've hit a couple different times, as well as increased fatty acid synthesis. So here you can see again, ethanol, you're going to be requiring a ton of NADH, and you're going to be accumulating a ton of NADH plus. And then you're also going to have your downstream aldehyde, acetate, and then eventually the acetyl-CoA. Because of this, you have accumulation of the triglycerides, ketones. This is essentially going to lead to lactic acidosis. And again, this is something that happens in the liver and is going to cause negative side effects. You're creating damage, again, because you're kind of stopping up the original kind of function of that region by using some of these cofactors that are required for other metabolic processes. So we've briefly mentioned ADH, ALDH. So next we'll talk a little bit about CYP2E1. So this only accounts for about 10% of ethanol metabolism and is only kind of incited during chronic ethanol consumption. Therefore, other substrates that are clearance is enhanced if you ingest ethanol chronically, you're going to also be upregulating CYP2E1, I guess, and function. And so other substances that are cleared by this enzyme are also going to be enhanced in their clearance. There is some susceptibility to toxins once that enhancement happens. And if we look at kind of the effects of some of the cofactors that are elevated here, again, the function of CYP2E, you have ingestion of ethanol. The resultant there is going to be your NAD+, and then you also see all of these oxygen radicals that are going to cause oxidative stress. So you can see that the resultant effect here, it can be great in terms of things like lipid peroxidation and DNA damage. So it's not just that metabolic process that you're looking at. You can see that there are other effects of those downstream cofactors as well. Again, CYP2E is going to result in ethanol being processed to aldehyde. And again, that's kind of the bottleneck in the ethanol metabolism process. Okay, so as we're discussing these enzymes, it's important to recognize, obviously, these enzymes are proteins that are encoded via genes, and some genes that encode for these proteins do have single nucleotide polymorphisms. And so this is kind of an interesting application of pharmacogenetics when we're looking at these enzymes that process alcohol. So there are specific gene clusters to ADH that have shown to influence risk for ethanol or alcohol use disorder. And so there's some strong association with ADH4, ADH1B. What's interesting that in ADH1B, this is found in East Asian populations, and that may actually allow for protection against AUD. They have a much faster metabolism of ethanol. And then there is also a SNP located in ALDH2*2, and this is going to result in a higher rate of esophageal cancer. And then in a SNP also located in I'm sorry, ADH1B, and this is shown in African Americans and may display lower risk of heavy drinking and ethanol related problems. And so it looks like here with these SNPs, in some instances you're getting a higher functioning enzymes, in some instances a lower functioning, and that's ultimately going to result in kind of the downstream effects of these SNPs on an individual. Within this lecture, there's a couple different hyperlinks that I've included. I'm going to click on this, so just bear with me because this is kind of another technological leap that I haven't done. I just want to make sure that you can see my screen. Okay. So I've included a link to, okay, really quick, I just want to make sure that, can you see a web page?
Yes.
Yeah.
Okay, good. So this is just a link in case you're interested to a study that shows genetic variants associated with alcohol dependence. And so some of the images in this particular study are really beautiful. I'm scrolling very quickly, I recognize, but just showing you some of the different SNP variants, and then also kind of the different areas of the body that are essentially affected by these different SNP variants. If you do not want to go as deep into alcoholic use disorder is what AUD stands for. If you're not interested necessarily in going this deep with the science, that's completely fine, but I will just recommend to read maybe the abstract and the introduction, because generally some of these abstracts and introduction can really clarify this problem. Usually it's kind of written from a much larger, broader stance, and so it can be very helpful in just kind of pulling yourself out of your textbook and reading kind of a specific introduction about this, the SNPs if you're interested in. So I just wanted to kind of give you an opportunity to see some literature related to what we're talking about in class. So like I said, there are a few different places where I've used these links, and so hopefully you find them helpful or useful. In terms of outside of SNPs, there are some polymorphisms, also large clusters that are associated with ALDH2. Again, they're implicated in this alcohol use disorder. They are most deficient for the ALDH isozyme. And so what happens in this instance, you can see that low levels are going to be essentially rewarding, and then high levels are going to have very toxic effects. And depending on if an individual is homozygous or heterozygous for this, it's going to influence the severity of this polymorphism. So the example that we see here is the AL2 SAR2 mutation. It essentially renders this particular enzyme non-functional. So if you go back to that metabolic pathway and you look at what happens, you can kind of predict that this would have a very toxic effect. Roughly 10% of Asian populations are going to be homozygous for this. And so they're going to have a very severe reaction to ethanol after just a single drink. And then roughly 30 to 40% of Asians are going to be heterozygous. So they have one functioning, one non-functioning gene, which means they probably have a less, I guess, they're creating probably less protein. And then because of this, they have an enhanced sensitivity of alcohol. So again, if you think back about genetics, when you were learning about heterozygous and homozygous, this is a nice application of that, and just showing you how that actually titrates out to the effect and response of ethanol metabolism. Any questions about the SNPs or the polymorphisms? Okay, I'm not being rude. I just want to make sure I keep my eye on the time, because I, again, don't want to hold folks up. Okay, so again, going slowly through that roadmap, we've reached the portion of talking about methanol. So methanol obviously is slightly different than ethanol in its chemical structure. It's often called wood alcohol. It's not for human consumption. Methanol and ethanol, though, do kind of have an interrelated relationship in a way, because methanol is often added to industrial alcohols. So it's not that industrial alcohol is not used for consumption. So if you, let's say, go to a lab and you have alcohol that's sitting on your laptop or your lab bench, that actually has some amount of methanol, and it's, again, to deter consumption of that. But it's also used as a solvent in many industrial, I guess, paint removers, shellacs, and things like antifreeze. And it can produce toxicity in as low as 10 milligrams consumption. So if you think about, again, when we ingest ethanol, we're doing it on the gram level, and here just 10 milligrams of methanol can have severe effects. What's interesting to note is that the onset of this takes quite a while. It's generally 12 or more hours in which you see this toxicity. Your symptoms can include headache, GI distress, pain, difficulty breathing, restlessness, and blurred vision. You essentially have severe acidosis. You're essentially forming formaldehyde as a downstream effect that you can see here. So methanol via alcohol dehydrogenase becomes formaldehyde. So it's almost like you're preserving yourself from the inside out. And then that can also via alcohol dehydrogenase become formate in the folate pathway. But here you can see kind of the site of where methanol poisoning is really treated via alcohol dehydrogenase. One way it's treated is via competition with ethanol. So ethanol is actually a treatment for methanol poisoning. We'll talk about that a little bit later, as well as we'll mention the other drug that's located on this slide up here. The formampidzole is going to also inhibit alcohol dehydrogenase and prevent some of these downstream effects. So just kind of, I feel like I just did this, but this is actually kind of a big deal because it's been in the news recently. And so obviously we're in the middle of COVID and folks are using hand sanitizers, but there's been some hand sanitizers that have actually had toxic levels of methanol in them. And so there is an expansive list of sanitizers that should be avoided, again, because methanol can go through the skin. And so if you're applying methanol to your skin constantly through the day, you could start to see some of these long-term toxic effects. And so there's been a warning posted via the FDA. So this is, again, just a hyperlink that I've included in the slide. If you have an interest in it, you can go check it out. But I think it's a nice kind of, you know, application of what we're learning in class, being very relevant to what's happening currently. Okay, so in severe cases, if you have, you know, if you have ingested large amounts of methanol, either orally or topically, can lead to respiratory distress, as well as coma. Okay, so in terms of treatments of methanol poisoning, again, these are just kind of the abbreviated ADME points that were brought out in the textbook. We talked about A, which is the administration that can be either oral or topical. Roughly takes 30 or 60 minutes to work its way into your blood system. And then when we talk about the metabolism, or the M of the ADME, it's metabolized via ADH and ALDH. So the treatment of the poisoning, interesting again, is going to be competes with ethanol for the alcohol dehydrogenase. So ethanol is essentially used to decrease the amount of formic acid that is generated. So you're competing for that enzymatic function and preventing these downstream outputs from occurring. For metoprolol, you would treat at 0.8 milligrams per liter of plasma levels. Are effective in inhibiting ADH. Do not use with ethanol. This is going to, again, promote the half-life of ethanol. So if somebody has consumed, let's say, a alcohol spiked with methanol, this probably wouldn't be necessarily the best treatment strategy, because it's going to prolong the ethanol in the bloodstream. And then kind of a long-term, I guess maybe another part of the treatment strategy would be treat with sodium bicarbonate to combat the acidosis that's occurring because of the methanol production. Okay, questions about methanol at all? Concerns? Okay. So we're gonna kind of, again, turn our focus back to ethanol. And because I think many of us have had some type of personal experience with ethanol, maybe not everyone, but some of these slides probably won't be a huge surprise to you when we're talking about things like the physiological effects of ethanol. So not surprisingly, it acts as a depressant. If at very moderate amounts, it's going to act as an anxiolytic, meaning it's going to decrease your anxiety, behavioral disinhibition. You know, some people are like, I feel nervous about X thing, I'm going to have a drink, and hopefully that'll kind of curb that. So there is some underlying pharmacology that actually supports that hypothesis of like having it kind of calm your nerves. But you continue to ingest ethanol, it can lead to uncontrollable mood swings and emotional outbursts. Later on, we'll talk about different regions of the brain that ethanol affects. Not surprisingly, it has some effect in the amygdala projections, which kind of, you know, has a role in things like fear and rage. So it's not surprising that we see that as an outcome of the effects. In a very large amounts of ethanol, it's going to mimic general anesthesia. So if we look at kind of the blood alcohol content that you see down here, we can actually see some of the clinical effects correlated there. So at those very low, you see sedation, subjective high, slower reaction times. At the 100 to 200 milliliter per deciliter, you have an impaired motor function, start speech, and ataxia. At 200 to 300, emesis and stupor. 300 to 400, again, that's where you're getting into those larger amounts that are going to mimic general anesthesia. You have coma, and then greater than 400, you're going to have respiratory depression or death. So again, it's going to be one of those things that overconsumption is definitely going to continue to depress specific regions of the central nervous system. And we're going to look at some of the molecular targets that kind of lead to that effect. So if we look at, we're going to kind of talk about alcohol consumption in two different ways. First, we'll talk about short-term and some of the short-term effects on CNS, and then we'll talk about some of the long-term effects on the central nervous system and on the body as a whole. That's probably more falling under the category of the alcohol use disorder. That's going to be the chronic use of alcohol. Here in the short-term CNS, it's going to, we've talked already about how it's influenced by body weight, by gender, by food consumption, the rate of absorption. Generally, it's going to peak about 30 to 60 minutes after you've consumed alcohol. It's going to have initial stimulatory effects, you know, at very low concentrations, maybe after a single drink, 30 to 60 minutes in, you will see giddiness, muscle relaxation, impaired judgment. That also probably would be that time in which you feel that anxiolytic effects. Mid-concentration, search speech and coordination, and unsteady gait and impaired attention. This slide is very similar to the last slide, just kind of giving you, again, some examples of concentration and symptomology. At high concentrations, you'd see failed vital signs, coma, and death. Again, at the lower end of those, lower end of those high concentrations, you would start to see respiratory distress, and then if it continued to progress, you would eventually see comatosis. Just recognize that if you do combine ethanol with other depressants, the concentration of this is going to shift to the lower end. And so if you have, let's say, a mid-concentration that you're ingesting of ethanol, but you're also taking some type of other depressant that, let's say, works on the GABAergic system, or maybe like a benzodiazepine, it's going to cause these effects to become exacerbated at far lower concentrations. And so you might see, again, any kind of these combination treatments resulting in a more severe response than you would otherwise predict. And we'll talk about drug interactions in some of the following slides. Okay, so in terms of acute treatment of intoxication, so it's going to depend on how you treat this, depending on the amount of respiratory severity. So again, the amount of alcohol that you've ingested is going to lead to maybe more severe results or responses. So you might have respiratory distress and coma based on the amount that you've consumed. Ranges from very careful observation, and I think being funny here, put Taco Bell, to intubation of the airway. Again, that's when you're getting onto that lower end of respiratory distress. The humor is just sad. But in those more, during acute intoxication, if you do go to the ER, you've started to see signs of respiratory distress. Often what they'll do if it is extreme intoxication, they'll do a stomach lavage or pumping, and then they'll keep that individual there for roughly 4 to 6 hours for observation and monitor their blood alcohol content during that period of time. Make sure that it comes down and that they're able to recover from any type of respiratory distress that occurs. Okay, so sites of ethanol action. So what's interesting about ethanol is it has a few different sites of action, a few different mechanisms by which it functions. It's not just it's not an agonist for a single site. So not surprisingly, you see it as an agonist for some of the inhibitory I guess, receptors that we've talked about. So we've talked about the GABA-A receptor. It's going to be an enhancement of that signaling. Glycine receptor, again, another inhibitory receptor system, you're going to see an enhancement. For NMDA receptor channels, you're going to see inhibition. If you remember what NMDA receptors do, they're part of the glutamatergic signaling system, and they're important for learning and memory. So it's not, again, super shocking when you think about some of the effects of alcohol, that one of the molecular targets is something that it would inhibit a molecular target that is responsible for learning and memory. It shows an enhancement for nicotinic acetylcholine receptors, an enhancement of 5-HT receptors, serotonin receptors. Again, that's part of the reward process that comes with, we'll talk a little bit about addiction in this lecture, and this is part of that reinforcement of addiction. Enhancement of G protein inward rectifying potassium channels, inhibition of voltage-gated calcium channels. If you remember what voltage-gated calcium channels do, they're going to lead to influx of calcium in the presynaptic side, leading to neurotransmitter release. So ultimately, if you're inhibiting those, you're inhibiting presynaptic release of neurotransmitter. Also, that's a type of kind of depression. And then large conductances calcium, voltage-gated activated potassium channels, and enhancement of those. So it really does act like a depressant in many of the molecular targets that we're talking about here. It's enhancing the inhibitory and essentially antagonizing or depressing the excitatory. So it's not shocking some of the symptoms that we see associated with it. Okay. Any questions about the ethanol sites of action? Okay. So, so the next kind of portion of this lecture, we'll talk, I think, more about kind of the more long-term effects of alcohol use. So we kind of just covered some of the acute. So now it's a kind of more the chronic. So AUD, it's alcohol use disorder. It's chronic relapsing and compulsive use of alcohol. If you're going to go with like the textbook description of it. There are essentially three kind of different stages of this. First, you have the binge intoxication. That binge intoxication is activating areas of the brain, things like the basal ganglia. That's important for procedural learning of routines and habits. Again, it's starting to entrain this idea of alcohol use being a positive experience. There's a release of dopamine and opioid peptides in the nucleus accumbens that reinforces use. So again, kind of the first binge intoxication is going to start to train regions of the brain that are very important for kind of addictive, like long-term effects, just because you're getting so much release of those happy neurotransmitters, things like dopamine. It's amazing how many choices we make in our life that are literally focused on getting that dopamine release. And it can be anything. I mean, this is kind of an aside, but I mean, if it's searching for food, if it's searching for, drink, if it's searching for sex, those are kind of all driven by dopamine. And alcohol is no different. The second step of addiction is going to be with withdrawal or negative effect. And then the last is going to be that preoccupation and anticipation. And we'll talk about these other steps in the future slides. So in terms of tolerance, as you ingest more, chronically ingest alcohol, you're going to observe that there is a tolerance that's reached, in which that means that you need to ingest more, essentially this higher concentration to get the same result. So you essentially become tolerant to that drug. And so you have to ingest more alcohol to get to the same place that you were able to get to, let's say, a few weeks ago. So you require a higher dose. There can be an acute effect, which occurs within hours. This is an adaptation of your central nervous system. You're not necessarily adapting to that the higher dose. And then in a chronic situation, you have a psychodynamic and a pharmacodynamic due to these alcohol metabolizing enzymes, meaning that you have an upregulation of those enzymes, and therefore you're able to consume higher concentrations and not necessarily have the same negative side effects. You have to, again, consume higher concentrations in order to get to the same place that you were previously. And that's, again, a much longer term effect of chronic consumption and your long-term upregulation of those enzymes. Lastly, dependence. And so this is dependence of alcohol can last for several hours to days. Again, the Symptoms for a dependence on alcohol is you've got motivational changes, sleep disruption, autonomic nervous system activation, tremors, and seizures. After 2 or more days, if you are in fact dependent, you can have delirium tremens, and those kind of manifest themselves as hallucinations, delirium, tachycardia, and fatal fever. So if you've ever seen somebody go through alcohol withdrawal, you kind of, this is probably the most visible form of that, where they're shaking and they're having these hallucinations. They're just not of this world, and also they're having this high fever at the same time. Even after this has passed, you can have the very long-term effects of anxiety, dysphoria, and depression. Again, you've kind of shifted your brain chemistry for so long that this is going to again have effects in other pathways in your brain. So this figure down here is really nice just because it does give you a good sense of where each one of these different symptoms would occur in the days since alcohol discontinuation. So if you look at the x-axis, you can see here that if you discontinue alcohol use and you are in fact dependent upon it, you have that all of these kind of psychological issues that can onset immediately. You can have seizures, alcoholic hallucinations, and then after 4 to 5 days, some of those symptoms are going to subside, but then you will still have the delirium tremens, and then again that very long-term insomnia, anxiety, tremor, palpitations, nausea, in some cases anorexia, but you see that it slowly tails off over time, and again your body's kind of regaining its homeostasis in the absence of this chronic use of a depressant. Okay, this came along at a great time because I've been talking for a long time. Okay, so a 50-year-old salesman was admitted to the hospital with acute appendicitis. He has no significant medical history, takes no medications, does not smoke cigarettes, and has an alcoholic beverage once in a while with the boys. He underwent an uncomplicated appendectomy. On the second hospital day, you find him to be quite agitated and sweaty. His temperature, heart rate, and blood pressure are elevated. A short time later, he has a grand mal seizure. You suspect he is having withdrawal symptoms from chronic alcohol abuse and give IV lorazepam for immediate control of the seizures and start to him on oral chlordiazepoxamine when he is more stable. So my question for you is, what are the chronic pharmacological effects of ethanol? And then what is the pharmacological basis for using benzodiazepines to manage alcohol withdrawal? So I haven't figured out quite the most effective way of sharing the screen so you can see it when you head to the breakout rooms. So I'm going to go ahead and just, again, have you work as individuals unless you super love the breakout rooms. So if anybody has any strong opinions, feel free to throw it up in the chat. But I think I'll have you all kind of process this on your own. I'm going to give you 3 to 5 minutes just because I think this might take a few seconds and some Googling to come up with these answers. And then once I see some private messages and some answers, then we'll go over kind of the collective answer. So yeah. So does anybody have any questions about this question? Oh, getting some answers here. I'll have to say it's very interesting to see how this is, I think this question in itself is a kind of a broad question. It's not asking something very specific when we're asking about the chronic pharmacological effects, because I'm getting answers that vary from like direct pharmacology to receptors to regions of the brain that are affected. And I think it's interesting to kind of see that interpretation. I would never ask something that wide open on an exam, but I do like kind of the different interpretations of this particular question that I'm getting right now. Yeah, awesome. Okay, so in terms of great answers, everyone. Like I said, I think everybody's hitting the answer kind of right on the head in one way or another. So symptoms of chronic ethanol toxicity. So you can have an alcoholic fatty liver, which we'll talk about here in a bit, alcoholic hepatitis, cirrhosis, liver failure, peripheral neuropathy, alcohol amnesic syndrome, pancreatitis, gastritis, fetal alcohol syndrome, nutritional deficiencies, particularly in thiamine, cardiomyopathy, and cerebral degeneration. So again, these are kind of all examples of symptoms of what happens after chronic alcohol use. This is part of the list. This actually probably isn't the entire list, because we're going to be kind of hitting, I think, not the entire list, but a separate kind of list a little later on. And then the second question that we have here is, what is the pharmacological basis for using benzodiazepines to manage alcohol withdrawal? Both alcohol and benzodiazepines enhance GABA receptor function. So if your body is used to this GABA receptor being activated, it makes sense that you would mimic that with a different pharmacological agent. And so in this case, using that benzodiazepine is you can essentially kind of decrease overall excitability, because the brain is essentially saying, oh my gosh, there's this depressant that we're used to that's not here. So we're becoming overactive, and the seizures is essentially the result of that. So this essentially explains why you have this cross-reactivity, explains why relatively long-acting benzodiazepines, things like lorazepam, can be substituted for alcohol in a detoxification program. Again, you're kind of just mimicking that GABA activity that ethanol shows, especially under chronic use. You're activating this GABA A receptors, and so in that absence, you're going to have overexcitation of the central nervous system. Okay, before I move on, does anybody have any questions about this particular concept check? And again, go ahead and throw it up in the PM. If you're a fan, if you're not a fan, if you think it's not the best use of class time, I'm happy to omit them. But I do think they're a nice kind of break from content for a second, and actually hopefully apply some of the material that we're going over. So again, any feedback you're willing to give me, I'd be happy to take. And can we have more concept checks? We won't get through all the material. There's so much material. I think we're already having that the side effect to that. But it's, yes, I agree. I think they're good too, because they allow you to kind of take a break and actually apply the material we're talking about. Participation has been not super high, but that's okay. Maybe they're just not everybody's thing. So I just want to make sure that that was the case, if it was the case. Okay, so in terms of the withdrawal negative effect stage, you're going to see a decreasing function of the reward systems in the ventral striatum, a recruitment in the systems of the amygdala. Again, the amygdala, you know, fear, rage, kind of generation, region of the brain that kind of gives rise to those types of emotions. And then you have a dependence that occurs in the corticotropin releasing factor. Norepinephrine and dynorphin are recruited, generating a strong drug-seeking motivation. And so you have these specific neurotransmitters or neurotrophins that are being released that are going to kind of prompt an individual to continue to seek out things like ethanol. So the craving stage, there is going to be a dysregulation of the prefrontal cortex that's going to affect the decision-making process. There are kind of two different systems that are affected in that region, the GO system of the anterior cingulate cortex and the dorsolateral prefrontal cortex engages the basal ganglia. Again, this is kind of go find this thing, this alcohol. And the stop is the ventrolateral prefrontal cortex and the orbital frontal cortex is going to inhibit the basal ganglia. So you're essentially kind of reinforcing this idea of like go seek out this thing that we need. This presents ultimately this kind of push-pull of these two systems as an impairment in decision-making process, again, because you're inhibiting the prefrontal cortex, spatial information, as well as behavioral inhibition. So you're essentially going to do anything, not do anything, but you're going to maybe do things that you would otherwise not do to kind of fulfill this craving that you're having. Okay, so consequences of alcohol. So it literally says the word hangover in your textbook. So the transient effects of alcohol consumption can be things like a hangover, headache, thirst, nausea, and cognitive impairment. Can have instances, if you've imbibed enough, you can have ethanol withdrawal, dehydration, and mild acidosis. This results in a very terrible day. Insomnia will generally also occur. You may, insomnia, next line there. Brain shrinkage can also occur after alcohol consumption. This is considered alcoholic dementia. This is a much more prolonged chronic exposure to alcohol. Can also reduce brain metabolism, meaning that the toxic substances that are generated by your brain are no longer being cleared as effectively. Other consequences, things like the Wernicke-Korsakoff syndrome. They're actually kind of two different syndromes. First, you have the Wernicke encephalopathy, which is reversible if you cease alcohol consumption. And then you have the Korsakoff syndrome, which is irreversible. So the encephalopathy, the Wernicke encephalopathy, you have confusional ataxia, abnormal eye movements, blurred vision, nystagmus, and tremors. Nystagmus is going to be that movement of the eye in tremors. And so again, if you withdraw, if you stop consumption of alcohol, these symptoms can be reversed over extended periods of time. They'll start to decrease. The second kind of part of the syndrome, the Korsakoff psychosis, it's irreversible. It's result and presents as severe anterograde and retrograde amnesia. And then both result from a thymine deficiency. So this can be treated with IV of thymine. And again, you can reverse the Wernicke encephalopathy via this treatment, and Korsakoff not as effective. That's a good question. So could you supplement, somebody asked, could you supplement thymine deficiency with thymine tablets just over time? You know, I think that's a great question, and we're at 11:50, so I'm going to stop there with that question. Maybe do a little Googling on my own over our break and come up with an answer for you when we return at 1 o'clock. Again, I don't want to hold you. I want to make sure everybody has time to go grab lunch. Does anybody have any questions or concerns before I let you go during this time? I'll take the silence as a good sign. If you do, please just go ahead and feel free to head out, go ahead and reach out, and I'll see you all at 1 o'clock. Have a good lunch.